All right, guys, welcome back. We're going to move into Chapter 13, Environmental Emergencies. So looking at the National EMS Education Standards, we've got a couple of them for this chapter. The first one is trauma. Use simple knowledge to recognize and manage life threats based on assessment findings for an acutely injured patient while awaiting additional emergency medical response. And the next competency is environmental emergencies, recognition and management of submersion incidents and temperature-related illnesses. So extreme hots and extreme colds can both be really difficult. Let's try again. So when we have patients that are exposed to extreme heat, the body's mechanism to try and regulate that temperature becomes overwhelmed. And we can start having heat-related injuries such as heat cramps, heat exhaustion, and heat stroke. Cold injuries are normally going to be our frostbite and hypothermia. So anytime we have hot or cold, we need to pay attention to how long the patient has been exposed and just try and recognize if their body has become overwhelmed. We also have unintentional exposure to water, and that can lead to either submersion or drowning and also lead into some of our hypothermias. As with all of our assessments, we're going to start with our scene size up, move into our primary assessment, get a good history, a secondary assessment, and move on to our reassessment. Same steps that we've had with all of our other assessments, repetition, repetition. So we're going to start looking at reviewing the dispatch information, trying to figure out as much as we can about the call that we're going to before we ever even get there. Once we're on scene, stepping back that 5,000-foot view, looking for scene safety issues, and then moving into our primary assessment. We're going to figure out the patient's condition, determine their level of responsiveness, introduce ourselves, ABCs, and then try and focus in on whatever their chief complaint is. These are the same steps as our other assessments. We're going to try and figure out any medical history and important information before we move into our secondary assessment. We're going to continue to use that sample history form. So our signs and symptoms, our allergies, medications, pertinent past history. So remember, this is when we want to focus in on history related to why they called us, last oral intake, and then any events associated with or leading up to the injury or illness and the reason why they called you today. So heat cramps are kind of the first heat injury that we would see as our body starts to become overwhelmed with regulating the heat in our body. So heat cramps is the first type of heat injury from heat exposure that we're going to see. So first thing you're going to see is kind of painful muscle spasms. This can occur after exercise in hot weather. You're normally going to see it in your calf muscles or your other leg muscles. It can lead into abdominal cramping, and the abdominal cramping at that point associated with the leg cramping leads you down the thought process of heat cramps. If it's just the abdominal cramps, then you could also be wondering if there is an acute abdominal problem along with the heat cramping. Treatment for heat cramps, pretty simple. We're going to move that patient to a cool place. We want to have them lay down, get comfortable, and the best thing for them is we're going to give them some fluids. Oral rehydration is great. If we can, give them some type of electrolyte solution, like Gatorade or rehydration salts or something if you have that. If the cramps don't get better, or if you have a patient that's really young or really old or has other like medical conditions, other chronic medical conditions, then we need to think about arranging for transport and getting them seen at a medical facility. The next heat injury that we might see from heat exposure is going to be our heat exhaustion. This occurs when our body temperature gets greater than 80 degrees. The next heat injury that we might see is going to be heat exhaustion. And this occurs when you're exposed to temperatures greater than 80 degrees, normally combined with high humidity for an extended period of time. This can also happen after vigorous exercise, but it doesn't have to be associated with exercise at those temperatures. It can happen at rest if you're exposed to 80 degrees with humidity over a long period of time. The signs and symptoms that we're going to be looking for our heat exhaustion is going to be profuse sweating, lightheadedness, dizziness, nausea. They may end up with a weak pulse or low blood pressure, but I really want you to kind of pay attention to the profuse sweating, as that's going to come into play as we move on and talk about some of the other heat injuries. Some people may have a predisposition for heat injuries, and so some of those things that may cause them to be more susceptible to heat injuries are going to be our very young or our very old. Like I said, if they have any pre-existing chronic medical problems, certain medications that we take, or the high air temperatures and high humidity. Treatment for heat exhaustion is going to be moving that patient to a cool place, and the treatment for heat exhaustion is going to start by moving the patient to a cooler place. If they're unconscious or nauseated or they're vomiting, our treatment for heat exhaustion is going to start by moving the patient to a cool place and start treating them for shock. Unless they are unconscious or nauseous or vomiting, same with our heat cramps, we want to give oral hydration. The best way to get fluids into our body is always going to be giving fluids by mouth. We want to continually monitor our airway, breathing, and circulation for those patients. And these patients, you do want to arrange transport to a medical facility no matter what. The most severe of our heat injuries that we're going to see is heat stroke. And this occurs when the body is subjected to heat for a more prolonged period of time and more heat than it can tolerate, and the mechanisms of the body are able to use their cooling mechanisms to cool us and get rid of that excess heat. The main way that we cool our bodies is through sweating. And so with these patients, we're going to start seeing that they lose that ability to sweat. It's also when the patient's body temperature reaches a level in which brain damage has occurred. So Heat stroke is an immediate emergency, life-threatening, that we need to treat very aggressively. Our signs and symptoms for heat stroke. First, we're going to see flushed, dry skin that feels hot to the touch. And like I said, with our heat exhaustion, those patients are sweating. It's as soon as we see that the body has lost the ability to cool itself through sweating and they're now dry and flushed that we can really key into that they've moved into heat stroke. At this point, they're probably going to have an altered mental status. They're not going to be very responsive. If they are responsive, it's probably going to be to verbal stimuli or unresponsive altogether. They will also have an internal temperature of greater than 104, which is why we're starting to see that brain damage happen. Treatment is going to be maintain their ABCs, our airway, breathing, and circulation aggressively, remove them from that heat environment, and try and get them into a cool environment as soon as possible. You want to remove excess clothing from these patients, and then we want to try and cool them. And one of the best ways, like we talked about, cooling is through sweating. And if they've lost that ability to sweat, we can help cool them by getting soaking them in water or putting sheets that have been soaked in water on them. You can get a hose and hose them down, put them into a shower, and get ice packs, whatever you need to aggressively cool these patients. If they are conscious and not nauseous, we want to give them small amounts of cool water. These patients are going to become nauseous very quickly. So unlike our heat stroke patients or our heat cramp patients, where we're just letting them kind of drink on their own, these patients, we want to limit the amount of cool water that they are getting as we are doing external cooling as well. With these patients, as with our heat exhaustion patients, they need to be seen at a medical facility, and this needs to be a rapid transport. This is a life-threatening injury that we need to get them to a hospital as soon as possible. Here we have a table just looking at those differences between our heat exhaustion and our heat stroke. Heat exhaustion, most of the time you're going to have a normal body temperature. They are still going to be sweating. They're going to have cool and clammy skin. They might be dizzy and a little bit nauseous. With our heat stroke patients, they're going to have that high body temperature that's dry to the touch without sweating, and they may be conscious or maybe semi-conscious. On the other end of the spectrum, we're going to have our cold injuries. And the first cold injury that we're going to talk about is frostbite. This can occur when body parts are exposed in a cool environment. So normally where we're going to see is those exposed areas, our face, our ears, our fingers, and sometimes our toes. Most common are going to be kind of our fingers, our nose, and our ears. The frostbite can occur at different temperatures, and it really depends on the temperature as well as the wind chill. And so you can see here there's a chart that kind of shows when frostbite can happen based on those two different criterias. As with our heat injuries, we have people who are more susceptible to cold injuries. Are people that are old and have poor circulation to their extremities, people that have medical conditions that cause poor circulation, like our diabetics. And then if you're exhausted or hungry, you can become more susceptible to cold injuries. There are different levels of frostbite, and the most superficial of those is called frost nip. This affects body parts where they become numb, they may start to turn red. Most people have had frost nip at some point. Eventually, those areas will lose that redness and that color, and they'll start to become pale. You may start to lose sensation or feeling in those areas. And what we do for those is we need to warm it up as quickly and carefully as possible, but we want to avoid rubbing. What happens is, as we get frost nip or any of the deeper frost bites, the fluid in our tissue is actually freezing. And as we rub, the fluid that has crystallized inside of our tissue can actually start to cause damage. So we want to warm by, you can just stick it in your armpit or stick it in a jacket or something like that. But like I said, avoid rubbing as much as we can. Deeper frostbite, we're going to start to see the skin becomes white and waxy. It may be firm and frozen at that point. The fluid underneath the tissue has frozen solid. You may start to see blisters. And once the skin begins to thaw, you may start to see different areas of purple or white. And what that is, it's mottling or cyanosis in the skin, where it's not getting the nutrients and the oxygen and different things that it needs, having been frozen. Treatment for our deep frostbite, we want to do the same thing that we do with all of our other assessments and treatments. We want to do a good scene size up, do a good primary assessment, figure out if there's any injury or figure out if there is any hazard to us as we go into this environment to treat the patient. Once we're there and treating them, we want to remove any jewelry or anything that, as the body starts to swell because of the freezing, that it could cause damage. And then we want to try and warm them up. It's really important that as we're warming these patients, if we can't keep them warm, it may be better not to warm them until we're in an environment where we can. We don't want to break those blisters. We don't want to rub the area. We don't put heat directly on it. And as much as possible, we don't want to allow them to walk if they have frostbite or cold injuries in their lower extremities. These patients, we need to provide prompt transport to a medical facility. Another cold injury that we could have would be our hypothermia. This occurs when a person's body temperature falls below the normal level. So once we have a body temperature below 95 degrees Fahrenheit or 35 degrees Celsius, they're no longer able to produce enough energy to warm up their body. So these people, once again, people that are susceptible, could be so people who are susceptible to hypothermia would be those who maybe don't have appropriate or adequate clothing for the temperatures that they're out in, or if their clothing has gotten wet. Anybody who's in a weakened state or has chronic pre-existing illnesses, which are the same things that we've looked at in our heat injuries as well. And then intoxicated patients or people who are using illegal drugs, they're very susceptible to hypothermia. They are susceptible to hypothermia because they have a false sense of warming. Signs and symptoms that we're going to look at for our hypothermic patients: if they're feeling cold, if they're shivering, decreased level of consciousness, lack of coordination, mental confusion, slowed reaction. With these patients, we want to be monitoring their body temperature if we're able to. If their body temperature drops below 90 degrees Fahrenheit or 32 Celsius, at that point, they're going to begin to lose consciousness, and they may have weak and slow pulses as well. Here's a good chart kind of showing some of the different temperatures associated with hypothermia and some of the things that you might see. As you can see, once we reach that 92 degrees Fahrenheit to 89, that's when we're going to start losing our coordination, becoming very confused, may become unresponsive. If we're between 88 degrees Fahrenheit and 80, they may appear to be in a coma, very weak pulses, unresponsive. And below 80 degrees Fahrenheit, they may appear to be dead. These patients can go into cardiac arrest where their heart has stopped. It's important that we warm them up as well. There's a saying that a lot of people have heard in EMS: you're not dead until you're warm and dead. So we need to warm them up. There are some caveats to that, but for the most part, if we find somebody in one of these hypothermic states where they've been out for a while, it is important to try and rewarm them and treat them the best that we can to try and restart their heart. Treatment for our hypothermic patients: we want to move them to a warm location, remove any wet clothing if they have it on, place them in a warm blanket or in a sleeping bag, anything we can to help warm them up. If they're conscious, we want to give them warm fluids to drink. If you don't have access to a building or anything and you're out just responding in your vehicles, move them into a heated vehicle if you can. Our hypothermic patients, we want to make sure that we handle them gently. This goes back to that cardiac arrest state. As they're cooling down, they can end up having lethal arrhythmias. And so we just want to make sure that we're not jostling them around, moving them kind of nice and gentle as much as we can. And all of our hypothermic patients, once again, this is one of those medical emergencies where all of our hypothermic patients need to be seen at a medical facility and evaluated by a physician. This is talking about our cardiac arrest with hypothermic patients. We mentioned this when we were looking at the This is talking about our cardiac arrest in hypothermic patients. And we talked a little bit about this when we were looking at the chart a couple slides ago. So if their temperature has dropped below 83 degrees Fahrenheit, their heart may stop and you'll need to do CPR. If you believe that they're a hypothermic patient and they've been dead for several hours, it doesn't really matter. We still need to start CPR, hook an AED up to them, try and rewarm them. And like I said, they're not considered dead until they are warm and dead. Another environmental emergency that we need to pay attention to is our drowning and submersion injuries. Each year around the United States, there are 3,500 people Each year around the United States, more than 3,500 people die from unintentional drowning. It is the second leading cause of injury and death among young children from ages 1 to 14. And this is basically any time there is a respiratory impairment or suffocation from being immersed in a liquid. It's not just children that we see this in. We can also see this around lakes. We see it especially around some of the holidays. You may see alcohol consumption and drug abuse while they're around water, and that is normally a contributing factor to those 3,500 people that die every year. So like I mentioned, we see this around lakes, but we also, a lot of the children that we see can be in swimming pools or hot tubs if they're not watched closely. And we can also see it in streams and rivers. Any body of water, any amount of water, we can see drowning and submersion injuries. Some of the hazards for specifically our young children that we need to pay attention to, like I said, any amount of water, any location. So our bathtubs, even toilets, mop buckets, anything like that can be a hazard for young children. There are multiple stages related to drowning. Normally, we're going to start out, the initial stage is panic. And as they become more and more panicked, they're going to become fatigued. They may become injured if they had been in a boating accident or something like that. If the water is cold, then they can start to become hypothermic. They can get entangled in seaweed, or they can also become entangled in seaweed. As these things happen, they become tired or entangled in something. They can experience a loss of orientation. That loss of orientation, along with the panic that they have had and the fatigue that they may feel, can lead them to have inefficient breathing. And if that cycle of panic and fatigue is not corrected, then it can lead to them being submerged and going into respiratory and cardiac arrest. Some of the signs and symptoms that we're going to be looking at. So as our patients become fatigued and they start to become more submerged, I mentioned that's when we're going to start to see the respiratory distress and cardiac arrest. But it really starts with, as they become submerged, small amounts of water will get into their mouth, it'll touch the larynx, and it will close off. There's a reflex that closes off the voice box so that no water can enter into the lungs. You may see coughing and vomiting or difficulty breathing because of that reaction. If not corrected, that coughing and difficulty breathing then leads to the respiratory arrest and cardiac arrest. We also need to pay attention, and like we've said in other chapters, not all trauma patients, or we also need to pay attention because, like we said in the assessment chapter, our trauma patients can often be medical and our medical patients can often be trauma. So with these submersion injuries, it may turn into a medical problem where they have respiratory arrest or cardiac arrest, but they may also have broken bones or spinal injuries because of how they got into the water. We could also see hypothermia depending on the air temperatures and the water temperatures that they have been submerged in. Our treatments for submersion injuries, if they're still in the water, we need to get them out. But don't go into the water and try and get them out unless you're a trained provider. It's very important that we take care of ourselves. We've said it before, I'll continue to say it. Our safety is most important. So get them out of the water if you can, if you're a trained rescuer, or if you have some way that you can reach them from the shore. Call for additional help if needed. Get extra people there. If there's any evidence of trauma, you need to be very careful in how you're moving them and protect them for spinal injuries, and then you move into your primary assessment. Your primary assessment is no different than we've done in all of our other chapters. We're going to correct our airway, breathing, and circulation problems. If we need to, we will begin CPR. If they're breathing adequately, then we want to administer high flow oxygen, dry them off, warm them up, and move on to our secondary assessment, checking for additional injuries. As with our hypothermic patients, any drowning victim, we want to start CPR on immediately, unless they have what we're going to call definitive signs of death. Some of those things would be if there's an injury incompatible with life, if they have blood pooling, or if they have their muscles stiffening, the rigor mortis has set in. Some of those things may have happened as they've been in the water. When a person is exposed to cold water, we have a natural reflex, and that's called the mammalian diving reflex. And that diving reflex, that mammalian diving reflex, actually slows our heart rate and our metabolic rate to a point where we may appear to be dead, but it also reduces the body's demand for oxygen. And so there have been cases of people who have been submerged for more than 30 minutes that have survived because of this mammalian diving reflex. So because of that, and because of our diving reflex, anytime you encounter a patient who has been submerged in cold water, we want to start CPR immediately and continue until they have been delivered to a medical treatment facility. Another environmental injury that we need to pay attention to is going to be our lightning strikes or lightning injuries. This is an electrical injury due to lightning striking either the person or near them, and it can cause cardiac irregularities or cardiac arrest. So, as with all of our other patients, first things we want to do, we want to first thing we want to do is assess and treat our airway, breathing, and circulation. We want to get oxygen on them. If we check a pulse and we determine they don't have one, we want to defibrillate. If we check their pulse and we determine that they do not have one, We want early defibrillation for these patients. Normally what has happened is that electrical activity from the lightning strike has caused their heart to go into fibrillations where it's just quivering. And so definitive treatment for that is to have a shock from an AED to try and get it back into a normal rhythm. So early defibrillation and CPR for those patients. And then all of these patients need to be transported to the hospital for evaluation. Along with cardiac dysrhythmias that we might see with our lightning strikes, the other thing that we might see is electrical burns. And oftentimes these electrical burns are going to be internal. So we may not see the injury right away. We may just see an entry point and an exit point from where the electricity entered and exited the body. But we always want to pay attention to where that entrance and exit is. Think about the path that it may have taken through the body and the internal organs that are in that path that may be damaged. We can also have our bites and stings. Sometimes our bites and stings would be discussed under poisonings. We're going to we can also have bites and stings. Because bites and stings often involve some type of poisoning or envenomation, because bites and stings often involve some type of toxin or poison or envenomation, we're going to talk about bites and stings in a different chapter, but just know that sometimes they fall under environmental, sometimes they fall under poisoning. So the summary for this chapter: heat cramps are caused by an electrical imbalance and dehydration. We're normally going to see those cramps in our legs, in the leg muscles, and sometimes in our abdominal muscles. We can have heat exhaustion, and our heat exhausted patients are still able to cool themselves, maybe not very efficiently, but they are able to cool themselves through sweating. They're going to become lightheaded, dizzy, a little bit nauseous. And then if not treated properly and aggressively, it will lead into heat stroke. Heat stroke patients have lost that ability to cool themselves at all. And at that point, you're going to see that they have stopped sweating completely. We have some of our most susceptible body parts for frostbite, including our face, our ears, our fingers, and our nose. It also has toes on here. Hypothermia. This is when the body is unable to produce enough energy to keep the internal organs or our core warm. This occurs when the body has lost the ability to create enough energy and enough heat to keep the internal organs at a acceptable temperature. Our hypothermic patients need to be rewarmed, even, like we said, if they appear to be dead or in cardiac arrest. We need to warm them up and transport them to the hospital. Drowning is a really big problem in the United States and other parts of the world. It can happen in various settings, not just at large bodies of water. It can also happen in mop buckets or toilets. So we need to make sure that anytime we suspect that the patient has had a submersion exposure, that we're treating them as a drowning. And then we have our lightning injuries. It's important to look for an entrance and an exit location of the electricity as it has passed through the body, and be aware that most of these patients are going to have some type of cardiac dysrhythmia. We're going to move into our review questions for this chapter. The first question, heat stroke occurs when outside temperature exceeds 90 degrees Fahrenheit, the body's heat eliminating mechanisms are overwhelmed, a person becomes dehydrated from excessive perspiration, or humidity exceeds 80%. And the answer for this one is B. The body's heat eliminating mechanisms become overwhelmed. Question number 2. You are called to the scene of a patient with deep frostbite. Which of the following actions would be appropriate for you to take? A. Provide pain medications. Rub the affected area to warm it up. Arrange for prompt transport. Or apply heat directly to the damaged tissue. And the answer for this one is C. Arrange for prompt transport. And our last question, when you encounter a person who has been submerged in cold water and is unresponsive, you should do nothing, the patient is already dead, transport him or her to a hospital because only physicians will be able to treat this patient, warm the patient before taking any other action, or start CPR immediately. And the answer for this one is D. Start CPR immediately. All right, guys, that is environmental emergencies. We're doing great. Let's move on to the next chapter.